Hello. Welcome to our webinar, The Intersection of Opioid Use and Disability, a focus on traumatic brain injury, offered by the National Association of State Head Injury Administrators. Strikingly, little is known about people who have both disability and an opioid use disorder. This webinar will offer an overview of the Administration for Community Living and the National Institute on Disability, Independent Living, and Rehabilitation Research, NIDLIRR's efforts in this area, and the NIDLIRR-funded INROADS project at Brandeis University that is researching this intersection. The focus will be on traumatic brain injury as a risk factor for opioid use disorder, as it affects opioid use disorder treatment engagement, and the accommodations that can improve the likelihood of treatment success and recovery from opioid use disorder. I am Gabriela Lawrence Soto, Chair of NASHIA's Training and Education Committee, and Haley Cushion, NASHIA's Training and Membership Coordinator, is our webinar organizer. Thank you for joining us. If you are unfamiliar with NASHIA, we are a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their family. NASHIA is the only organization representing state employees who work in support of individuals with brain injuries and their families. Our members come from a variety of settings and include state agencies, advocacy organizations, and healthcare. Many of our members have their own lived experience with brain injury. NASHIA is busy advocating for systems change and funding at the federal level, providing technical assistance to individual states and federal organizations, and developing and presenting relevant training and education opportunities like this webcast and our annual State of the States conference. For your convenience, 4 handouts can be located on the handout section of your control panel. This includes today's PowerPoint and additional handouts. You will have an opportunity to ask questions at the end of the live session if time allows. To submit a question, please use the questions panel. If we run out of time, the presenters will respond to your questions via email. Certificates of attendance from NASHIA and continued education credit from CRCC and NSW are available for the live and recorded session of this presentation. You will also be able to submit questions for the presenters post-session to training@nashia.org, as well as for certificates and CEU requests. Our objectives for this presentation today are to outline a conceptual framework for how and why disability and opioid use disorders may overlap, describe how traumatic brain injury is a risk factor for future opioid use disorder, understand how symptoms of traumatic brain injury can interfere with the traditional substance use treatment approaches, and identify recommendations that would improve care for people with traumatic brain injuries who are in opioid use treatment. And now we are pleased to introduce our presenters. We have Dr. Sharon Reif. She is a senior scientist at the Heller School for Social Policy and Management at Brandeis University and Deputy Director of its Institute for Behavioral Health. Dr. Reif has over 25 years of experience conducting health service research related to substance use treatment, focused on treatment systems, access to care, quality of treatment services, and recovery. Her interests extend to the intersection of disability and chronic medical problems, including pain with alcohol and drug use and misuse. Dr. Sharon Reif is a program officer at the National Institute on Disability, Independent Living, and Rehabilitation Research. Her research portfolio at NIDLIRR focuses on disability health policy and aging with long-term disability. Dr. Rachel Psycho Adams is a scientist at the Institute for Behavioral Health at the Heller School of Social Policy and Management at Brandeis University. She is a health service researcher with expertise examining co-occurring substance use and mental health conditions following traumatic brain injury. Dr. Adams is the co-principal investigator of the INROADS study, intersecting research on opioid misuse, addiction, and disability services, funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. She is a multiple PI on a new R01 from the National Institute of Mental Health and the Office of the Director at NIH, which will integrate data from the Department of Defense and Veterans Health Administration to enhance suicide prevention efforts for military members returning from deployments. Lastly, we have Dr. John Corrigan, who is a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University and the director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. He is editor-in-chief of the Journal of the Head Trauma Rehabilitation and directs the Ohio Brain Injury Program, the state of Ohio's designated lead agency for brain injury policy and planning. Dr. Corrigan has received many awards for his service and research, including the Brain Injury Association of America's William Field Cavdis Award, the 2007 Robert L. Moody Prize, and the American Congress of Rehabilitation Medicine's Gold Key Award. And now to our presenters.
Haley, I do not see the screen. There you go. Thank you. Okay, hello, my name is Sharon Reif. Thank you to NASHIA for inviting us to talk about the intersection of opioid misuse and disability. The opioid crisis remains at the forefront of national attention, and rightly so, and it affects people with disabilities as well. There are particular implications for people who have brain injury, and we are pleased to be able to share our knowledge with you. As I said, I'm Sharon Reif. I will be presenting an overview of our INROADS project on this intersection of disability and opioid use disorder. And my colleagues Rachel Seiko Adams and John Corrigan will present on TBI in this context, both an overview and thinking about accommodations for people with traumatic brain injury. Sarah Ruiz from NIDLIRR will start us off with an overview of NIDLIRR's work in this area. The INROADS project at Brandeis University is funded by a grant from NIDLIRR. The information that we're sharing here represents the authors and not NIDLIRR, aside, of course, from Dr. Ruiz's portion. We have no other disclosures, although Dr. Adams also has an appointment at the VHA in Rocky Mountain Mental Illness Research and Education Clinical Center. So we're going to start off before we get into our presentations to ask a couple questions about the audience. It will help us understand who we're talking to. Our first question, Haley, is what is your primary area of expertise? Haley will open the poll and we ask that you guys will click on the answers. We're interested in whether your primary expertise is brain injury, substance use disorder, or something else.
All right, and I'm going to close the poll. And here are our results. The majority of everyone selected other area of expertise. Then we have 37% with brain injury experience and 16% with substance use disorder experience.
Great, thank you, Haley. And for that, we will try to be a little more specific about substance use disorder as we're going through and talking. I'm assuming that that other may have included people who are experienced with both of these topic areas. Our second poll question is, what type of work do you primarily do? Are you somebody who's mostly clinical? Are you mostly administrative? Or are you mostly a researcher or something else?
Okay, we are getting close to closing the poll. And Sharon, there are results.
Great, thank you.
All right, it seems that half of our attendees are in the administrative side of things, with 21% in clinical and 28% in research or other areas of work.
Okay, thank you very much. And then the last question is, how familiar are you with approaches to substance use disorder treatment? Not at all, somewhat, or very?
Okay, we're getting in those results right now. Go ahead and choose your final selection. Okay, it seems that we have over half of our attendees are somewhat familiar with the approaches to substance use disorder treatment.
Okay, thank you, Haley, and thank you, attendees, for answering these questions. And also, I meant to say thank you for being on and listening to us. So very briefly, it seems that most people have limited expertise, or their primary area of expertise is not substance use disorder. Many of you are administrative and some experience with substance use disorder treatment. So we'll try to make sure that we're paying attention to that as we go through. At this point, we will start the webinar with a brief overview by Sarah Ruiz about NIDLIRR and its focus on opioids and opioid misuse.
Thank you, and good afternoon, everyone. My name is Sarah Ruiz, and I'm a program officer at NIDLIRR, the National Institute on Disability, Independent Living, and Rehabilitation Research. As others have alluded to, there's a group that's been disproportionately affected by the opioid public health emergency, people with long-term disabilities, but they have received limited attention. This presentation will summarize some of NIDLIRR's work in this area. NIDLIRR is a subcomponent of the Administration for Community Living. We fund applied research emphasizing the social model of disability, or the interaction between the individual and environmental factors in facilitating health, community living and participation, and employment outcomes among people with disabilities. Last year, we celebrated our 40-year anniversary, and our budget is approximately $108 million per year. Our mission is to generate new knowledge and promote its effective use. In this slide, I've shared some key links to documents for those interested in learning more. So why is research on opioid misuse or opioid use disorder among people with long-term disabilities important? Following a literature review by ACL staff on the opioid crisis in older adults and people with disabilities, we found very few studies focused on people with disabilities and opioid use disorder. As many of you are aware, there are a cascade of disparities for people with disabilities concerning everything from basic preventative care to quality of care and mortality. Two of the most common secondary conditions in the research literature are chronic pain and depression, both risk factors for opioid use disorder. Conversely, there's reason to believe many people with disabilities have excellent self-management skills and could be less likely to develop an opioid use disorder than the general population, even on long-term opioid therapy. They have advanced self-care skills because in the absence of adequate self-care, an acute event can occur quickly, and adaptation and resilience in daily living are typical for people with long-term disabilities. They have several decades to hone their adaptation skills. In an effort to understand whether NIDLIRR should invest in dedicated research on opioid use disorder, we released an RFI, a request for information, to hear from our stakeholders. So I'm going to touch very briefly on the RFI findings. So 3 findings. The first finding was that there were several studies showing that people with disabilities may be more likely to misuse opioids. In looking a little bit more into that, our researchers have hypothesized that the reasons they may be misusing may be different than the general population. For example, a recent study found people with disabilities misuse opioids to survive, in particular to sleep and function so they can work and take care of their families. And After removing mental health diagnoses, it's unknown whether other groups of people with disabilities are more or less likely to develop an opioid use disorder. And for the second finding, the major takeaway was that the same factors that put individuals at risk for a traumatic injury also put them at greater risk for misusing opioids. And this was true for both people with traumatic brain injury and spinal cord injury. The final finding concerned access. This finding is at the heart of the matter from NIDLIRR's perspective. Not surprisingly, we heard quite a bit about physical accessibility, especially in pre-ADA buildings, but we also heard wide-reaching stories of treatment providers that did not know how to accommodate for people with disabilities. There were many reports of limitations in insurance coverage, in particular in the Medicaid program where people needed personal assistance with bathing, dressing, transferring. And a second part of this finding was the unintended consequences of the CDC guidance. And we are excited about the recent tapering guidance released by the department. So following the RFI findings, NIDLIRR decided to fund 2 research projects to try to begin to understand the relationship between having a long-term disability and developing an opioid use disorder. One of them is going to be discussed today, and our grantees have been developing issue briefs and fact sheets on different topics that were identified as a gap or priority areas through our RFI and our stakeholder meetings. I've included links to those resources. And finally, I'd like to take a moment to share a little bit about the ACL opioid crisis response. Last fall, ACL convened an internal task force to review stakeholder recommendations and determine next steps in our agency response. The task force identified 2 priority areas, one focused on access to care for those with opioid use disorder, and one around the experience of pain and pain management. It should be noted that ACL has not received dedicated funding to address the opioid public health emergency, so our focus has been on using existing resources and programs to address these 2 priority areas. We appreciate any feedback or resources you can provide to advance our efforts in this space. Please take a look at our website, www.acl.gov/opioids. Thank you for your time, and please feel free to contact me directly if you have any questions.
Thank you, Sarah. We are really so pleased that NIDLIRR is focusing on this topic area that is of immense importance to everybody, including people with disabilities. I will now provide a brief overview of the intersection of disability and OUD and the INROADS project. As has been mentioned, there's some context about disability and opioid use disorder. There's some evidence that suggests that people with a range of disabilities may be at higher risk for substance use disorders, up to 50% greater risk for people with traumatic brain injury, for example. Further, the type of substance use, such as people who combine alcohol and drugs, may be greater among people with disabilities. And some evidence suggests that opioid misuse may be higher among people with disabilities. Opioid misuse may be higher among people with disabilities, but that may reflect the higher prevalence of opioid use in this population related to the higher prevalence of pain. But even in the midst of the national opioid crisis, we know very little about this intersection of OUD and disabilities, and even less in the context of OUD treatment. This is a conceptual representation of how the INROADS project is considering the intersection of OUD and disability. If you look on the left, the circles indicate the most commonly considered pathway about opioid use disorder that we hear about in the news and elsewhere. It's the prevalence of pain, the use of opioids amongst people with pain, and the misuse of opioids by people prescribed them. This certainly happens. It's an important pathway, and because the prevalence of pain is higher in people with disabilities, it is particularly an important pathway in this context. However, if you look at the circles in the middle, we know that many people with pain do not misuse opioids. That's particularly important to acknowledge for the disability population, and that many people may have substance use or opioid use disorders regardless of pain and prescription opioid pathway for many reasons. This may include family history or history of trauma or co-occurring conditions. All of those things are risk factors for substance use and opioid use disorder. We also know that people who have opioid use disorder, many do not access treatment. And of those who do, many do not access medications for opioid use disorder, which is the frontline evidence-based practice. Last, on the right side of the slide, you can see that all of this is in the context of social determinants or needs, such as access to treatment, housing, and social supports, as well as the effects of stigma and discrimination. These social determinants can also be bidirectional. Substance use disorders may lead to these circumstances, or substance use disorders may be a reflection of these circumstances. And that's important to consider as we go through and think about this intersection of OUD and disability. I'd like to say for a moment that OUD medication treatment is safe and effective. These medications are considered frontline treatment, and at least one medication will work for most people, including people with disabilities. It's important to note, however, that there may be specific considerations for people with disabilities, including how they can take medications, the ability to go to daily treatment, which is often required for certain medications, pain and pain treatment, and combinations with other medications such as benzodiazepines. Generally, we know that the vast majority of people who have a substance use disorder do not receive treatment. Household surveys indicate that only 13% of people who have a drug use disorder do so. It turns out that most of these people who do not get help don't think that they have a problem that needs treatment. Yet there are some people who think they need help but did not get treatment. The reported barriers to treatment are wide-ranging and are generally consistent over time. Many people are not ready to stop using, but otherwise barriers include financial issues, stigma, and lack of knowledge or access. We also know that barriers exist for people with disability that apply to all levels of healthcare. These include, again, stigma, lack of accessibility, which may be geographic or physical accommodations, lack of accommodations more broadly, transportation issues, providers who don't take Medicaid or health insurance, concerns about having pain adequately treated, and provider beliefs, as Sarah had mentioned earlier, that medication treatment may not be appropriate for complex patients. History of limited accessibility by substance use disorder treatment providers has also been present, and we know that that is in terms of physical accessibility and ability or willingness to offer accommodations. Peer support is one example of where there's particular value at the intersection of disability and opioid use disorder, and where accommodations could be easily made. We know that people who have opioid use disorder and people with disabilities benefit from peer support, and generally this has the same goals: enhancing self-efficacy, empowerment and self-care, reduced isolation, and reducing the likelihood of needing more intensive care for the disability or for the opioid use disorder. We do note that we have found no models in the literature that address both opioid use disorder and disabilities other than the overlap with mental illnesses, although we have heard from people that we're talking to that these models do exist. Generally, to meet this intersection, peer support should be flexible and adaptable and may require extra training for the people who are providing it. Use of technology is a great example of how peer support can be adapted. It can be accessed 24/7 without appointments or need to get there. Responses need not happen in real time, although they often do, reducing the pressure on people for whom communication may be more difficult. It reduces social isolation and enables access to a wider range of people than you might otherwise encounter. And it may reduce fear of stigma or unpredictable behavior that may happen in person. Technology approaches have been developed and tested for people with cognitive deficits, psychiatric disabilities, and other conditions. So I'm going to stop here and hand this over to Rachel Seiko-Adams. This was just a selected overview of our approach to expand the base of knowledge around the intersection of OUD and disability. Dr. Adams will bring the focus of the remainder of the webinar onto traumatic brain injury specifically.
Thank you, Dr. Reif. So I will now discuss the specific risk factors that may converge for people who have had a traumatic brain injury, which may make them uniquely vulnerable for opioid misuse and opioid use disorder. As Dr. Reif mentioned, one of the key subpopulations that we are very interested in focusing on for our INROADS study is persons with a history of TBI. Since we were funded a year ago, we have 2 new publications in this area and an issue brief. Together with my INROADS colleague, Dr. John Corrigan, we published a commentary in Addictive Behaviors, targeting substance use treatment providers to help them think about why it is important to understand history of TBI in their practice, and also why people with a TBI may be more likely to have an OUD and require accommodations for successful substance use disorder treatment. Next, we published another commentary in the Journal of Neurotrauma with another NIDLIRR-funded TBI researcher, Dr. Kristen Dams-O'Connor at Mount Sinai, which synthesizes what is currently known about the risk for opioid misuse and OUD following TBI, and why we think persons with TBI may be uniquely vulnerable to these problems. I'll be going over these main points from this commentary in my talk today. Lastly, together with our INROADS team, we produced an issue brief targeting substance use treatment providers, which summarizes findings from our commentaries and also describes specific accommodations which they could make to improve the likelihood of successful substance use disorder treatment for persons with TBI. We encourage you to read and share these resources widely. All of them can be found on our INROADS website listed on this page, and the issue brief is also included as a downloadable attachment to this presentation. This slide provides an overview of the specific risk factors that we believe increase the risk for opioid misuse and opioid use disorder among persons with TBI. I will be going over each one in more detail in this presentation. Substance use is a known risk factor for TBI. Persons with a history of TBI are more likely to have pre-injury substance use problems. Further, about 1/3 to 1/2 of TBIs occur while individuals are intoxicated. After injury, many individuals do reduce or stop their drinking for a period of time, yet many resume their pre-TBI drinking levels by 1 to 2 years post-injury, and some even increase their drinking. Substance use following a TBI may reduce brain healing, impede rehabilitation, and increase the risk for future TBIs. We note that this cycle has not yet been studied specifically for opioids. There has been growing evidence that experiencing a TBI during childhood may increase risk for future substance use problems. Several of these studies have been conducted with birth cohort studies, which have been able to follow large samples of children with and without TBI into their adulthood. Findings from the NIDLIRR-funded TBI Model Systems longitudinal study, which follows adults who received inpatient rehabilitation for TBI, found that adults with a TBI prior to age 6 were more likely to misuse alcohol or use illicit drugs following the new adult onset TBI that brought them into the Model Systems study. In collaboration with researchers from the Army STARS study funded by NIH, we also found that soldiers who experienced a childhood TBI before the age of 12 were more likely to report increased binge drinking upon return from a deployment associated with the Iraq and Afghanistan conflicts. Headaches are one of the most common physical complaints following TBI in both civilian and military populations, as well as across TBI severity. Following deployment-related TBI, headaches are commonly comorbid with other conditions and post-concussive symptoms, such as PTSD, depression, or pain, and migraine-like features are common. A study of adults with moderate or severe TBI found that 1/3 of individuals reported new or worse headaches at 1 year and 5 years post-TBI, suggesting that the headaches did not resolve for 1/3 of these individuals experiencing them up to 5 years later. While opioids are not indicated for headaches, we speculate that the likelihood of opioid receipt may increase, especially when pain is chronic. Acute and chronic pain are common following TBI in both civilian and military populations. Another TBI model system study of adults with moderate to severe TBI who had received inpatient rehabilitation found that the prevalence of chronic pain following TBI was estimated to be over 50% of the population. Chronic pain following TBI is associated with functional disability and mood disorders such as depression, which on their own increase risk for future substance use problems. We know that both acute and chronic pain have been drivers of prescription opioid receipt in the United States. So this may significantly increase the likelihood of prescription opioid use following TBI. This slide depicts a visual from our Journal of Neurotrauma commentary in which we show that middle-aged community-dwelling adults 5 years following their TBI may be at high risk for chronic pain. Here we're focusing on adults in their 40s, stratified by sex. The orange bars show community-dwelling adults 5 years post-TBI compared to adults without a history of TBI in blue. On the left side, we found that men with TBI in their 40s reported more than twice the rate of chronic pain compared to adults without a TBI, 60% versus 28% respectively. Similarly, on the right side, we found that 46% of women with TBI in their 40s reported chronic pain compared to 28% of women without a TBI. These findings overlap with a demographic particularly at risk for opioid use disorder and overdose deaths in the United States, males in their 40s. During the conflicts in Afghanistan and Iraq, many military members have experienced a combat-related TBI. Many of these injuries have occurred during blast-related events, which have included improvised explosive devices, and they may have included exposure to other traumatic experiences. For military members who experienced a TBI while deployed, we know that TBI rarely occurs in isolation and commonly occurs in conjunction with post-traumatic stress disorder and other psychological health comorbidities. The term polytrauma clinical triad was developed by the military and veterans communities to capture the comorbidity of TBI, post-traumatic stress disorder, and pain often present in this population. This slide depicts findings from one of our recent papers in the Journal of Head Trauma Rehabilitation, which examined the prevalence and coprevalence of TBI, PTSD, and chronic pain among soldiers returning from an Afghanistan or Iraq deployment who also used one of the Veterans Affairs polytrauma system of care facilities in the post-deployment year. We found that among users of the polytrauma system of care in the VA, chronic pain was the most common polytrauma condition. However, chronic pain, PTSD, and TBI were more frequently found together than in isolation. You'll see here in this visual that over 1/4 of the sample qualified for having the polytrauma clinical triad. This group was also most likely to receive opioids in the VA during the post-deployment year, including receiving greater than 30 days supply of opioids in the year in the VA. This slide presents findings which have found that individuals with moderate to severe TBI are at increased risk for opioid receipt and overdose deaths. A study by Dr. Hammond and team found that over 70% of patients with moderate or severe TBI were prescribed opioids during their inpatient stay, and almost half of these individuals were prescribed opioids during the last 2 days of their inpatient stay. This suggests that many individuals may be discharged from rehab with opioid prescriptions, and it is unclear what education they may have received about safely tapering from opioids or risks for dependence. Another study highlighted earlier by Dr. Ruiz used data from the TBI model system study and identified cause of death based on death certificates, and found that after surviving a moderate or severe TBI and receiving inpatient rehabilitation services, a person's life expectancy was 9 years shorter. TBI increased the risk of dying from several causes. Persons with TBI were more than 11 times more likely to die from an accidental drug poisoning. And among accidental overdose deaths, 90% were drug-related, including 67% from opioids, 14% involving psychostimulants, and 8% alcohol. While many studies have examined opioid receipt among military members and veterans, only a few have explored how having a TBI diagnosis may influence likelihood of receiving prescription opioids. A recent paper of ours, published in Military Medicine, examined active duty soldiers returning from an Afghanistan or Iraq deployment in fiscal years 2008 to 14. And we looked for predictors of any opioid prescription receipt and long-term opioid utilization during the post-deployment year in the military health system. We found that soldiers with a TBI diagnosis were significantly more likely to receive an opioid prescription than those without a TBI diagnosis, 58% among those with a TBI diagnosis compared to 35% among all others. Soldiers with a TBI were also more likely to use an opioid long-term during the post-deployment year, which is a risk factor for numerous adverse opioid-related outcomes, including overdose and development of opioid use disorder. Another study of Afghanistan-Iraq veterans using the Veterans Health Administration found that among those with a TBI diagnosis, 21% filled an opioid prescription, and 25% of this group went on to use opioids long-term. Another important thing to consider with this population is because of the increased risk for post-traumatic stress disorder and other psychological health problems, military members and veterans with TBI may be more likely to receive concurrent opioids and benzodiazepines, which can further increase risk for overdose. In summary, the take-home messages so far are that persons with TBI are getting more exposure to opioids than people without, and are at increased risk for opioid overdose. In addition to the risk factors that we have detailed so far, which increase risk for increased prescription opioid receipt and overdose, we also want to highlight that certain neurobehavioral changes associated with a TBI may further contribute to risk for substance use problems. For instance, cognitive deficits associated with TBI, including memory problems and executive functioning limitations, may lead to medication mismanagement and poor adherence to prescribed dosing. TBI may increase the likelihood of mood disorders, sleep disturbance, and traumatic stress, which each are independent risk factors for substance use problems. Prefrontal cortex damage to the brain may increase impulsive behavior following TBI, making it more difficult to self-regulate substance use. And for some individuals, these neurobehavioral changes may converge following a TBI to increase risk for opioid misuse or opioid use disorder. So far, we've been talking about how TBI may be a risk factor for post-injury opioid misuse or opioid use disorder. But we also want to highlight that the opioid epidemic in the United States may be leading to additional brain injury. During an overdose, respiration is suppressed or stopped, denying oxygen to the brain. This can lead to anoxic brain damage if completely denied, or hypoxic brain damage if reduced. Similar to TBI, anoxic or hypoxic damage may inhibit executive functioning and self-regulation, further increasing risk for ongoing opioid use disorder. Overdose also may result in falls, further increasing risk for future TBI. This is an infographic from our issue brief that we mentioned earlier that we developed for our INROADS study targeting substance use treatment providers. Here we show that history of TBI is common among persons with substance use disorder. Moving from left to right, we first show that previous studies in the United States have found that about 20% of non-institutionalized adults has experienced at least one TBI with a loss of consciousness in their lifetime. Estimates of TBI are at least double among those with a substance use disorder, and maybe even higher among individuals with both substance use disorder and mental illness. These findings are based on work with other substances. We suspect these patterns may be true for opioid use disorder as well, but more study is needed. So at this point, I'm going to hand it over to our colleague, Dr. John Corrigan from Ohio State University.
Thank you, Rachel, and I'm assuming people are able to see this slide. I'm going to be talking about substance use disorder treatment specifically, but want to set two contextual kind of overviews. One is, as Rachel just indicated for that last bit of estimates, that most of what we know about response to opioid use disorder treatment is generalized from substance use disorder treatment more generally. There are no specific studies yet, although I think the clinical impression is that everything that goes for substance use disorder treatment generally applies particularly in opioid use disorder treatment. The other context that I don't have the opportunity, the time to show you the data for today is that persons with a history of traumatic brain injury fare less well, have worse outcomes in substance use disorder treatment than fellow clients and patients who have not had a history of traumatic brain injury. And that shows up in the form of having more treatments and having more failed treatments, often being closed with the indication of non-compliance. So what are some of those reasons for these negative outcomes? I'm going to talk about three very quickly. The first is
Dr.
that
Corrigan,
there are the neuro.
this is Haley. I'm sorry to interrupt. Can everyone see his screen?
No.
Oops.
You see the mouse.
You see the mouse.
There you go.
Thank you.
See some other stuff there too. Okay. All right. So I hope you're seeing a slide that says 3 reasons for negative outcomes. Is that with the first being neurobehavioral consequences?
Yes.
Good. Great. Thank you. So the neurobehavioral consequences of traumatic brain injury can undermine the ability to just participate, at least conventionally, in treatment. We don't think about it, but there is a cognitive load to being in substance use disorder treatment. It just requires greater concentration. It requires greater memory. It may and thus also requires more higher level cognitive abilities, whether that's in the form of needing to learn the rules of a new program, needing to learn the vocabulary of a treatment approach, or even being able to stay focused while in group treatment, which is more difficult than in individual. So there is a cognitive load that we often overlook, and as we know, of course, persons with traumatic brain injury are more likely to have problems with cognitive function. There also is a tendency to misattribute by both staff and peers, misattribute behavior that an individual may be displaying. So for instance, it may not be uncommon that somebody is hyperverbose. They talk too much in group. And the assumption may be made that that's intentional, or a peer may conclude they think they're better than me, and they thus get more time. When simply this hyperverbosity may be a disinhibited behavior that's a consequence of the traumatic brain injury. We see it in other ways too, maybe missing appointments or not following through on homework. And so if the staff or peers decide that that's something intentional that the person is doing and reflects their motivation for change, then there can be a disconnect with the individual with a traumatic brain injury who is in that treatment program, because they may still see themselves as very committed to change. It's just that I'm not good, I forgot to set the alarm, but they're being confronted for having missed an appointment or not done some kind of follow-up. So a big emphasis of training with substance use disorder treatment staff needs to be, that this can happen. It doesn't always happen. Behavior can come from either a neurologic or a psychological basis, but they need to be thinking about both. We've developed a resource at Ohio State or at the Ohio Valley Center that tries to help non-brain injury professionals understand what some of those behaviors are, how to recognize them in their interaction, and then some simple accommodations for how they might approach the individual differently to minimize the effects of those cognitive and behavioral impairments. Many states have similar kinds of resources that are available for all kinds of professionals who may be working with persons with traumatic brain injury. A second reason for negative effects is that there are just greater co-occurring disorders among persons with traumatic brain injury. I use this slide, even though it's a little bit dated, just because it is so telling. 1 year in Kentucky, all clients coming into their state-supported substance abuse treatment program were screened for a history of traumatic brain injury. So they were coming in for substance use disorder treatment, but what you see there is the greater likelihood of various kinds of other mental health issues, greater likelihood as their history of traumatic brain injury with loss of consciousness increased from none to one to more than one. There are many examples of this relationship in the research literature now. But it's not just the other psychiatric conditions. We know there's more co-occurring, higher prevalence of traumatic brain injury among co-occurring populations, but there are a host of symptoms that and disorders that are the effect of traumatic brain injury that can also then be impinging upon, need to be addressed in some way, taken into account as part of kind of a holistic approach to a person's treatment. So, the bottom line here is that these various kinds of co-occurring conditions almost make it certain that this individual will be a more complicated or more complex case for the substance use disorder professional. And rather than that being a reason maybe to screen out or say, I can't help, what we need to do is recognize that, embrace that complexity and realize that, gosh, in substance use disorder treatment, I think most of our patients and clients are complex. A third then reason for the poorer outcomes is that there's just less ability to sustain improvements that are gained through treatment without some kind of external structure. And this is from one study that was done here in Ohio. It was an integrated dual diagnosis treatment program. And the key here is to understand that staff who were working with clients had no idea of who had a traumatic brain injury in their past and did not. But they were asked, if this program, the supports in our dual diagnosis treatment program, were pulled away, what's the prognosis for each of the clients, and how might they fare without it? And what you see there on the left is that persons with traumatic brain injury are almost twice as likely, the clients with TBI are almost twice as likely to be judged as they are not going to succeed. They're going to need more, ongoing intensive support, and the reverse of that being that those without traumatic brain injury are more likely to be judged as able to succeed even with minimal or no support. Interesting, and don't have time to show it here, but actually the persons with traumatic brain injury had less morbidity going into the program than those without. But after being in the program, staff are saying the persons with traumatic brain injury are going to need more ongoing supports to sustain the benefits. So what would we recommend for treatment of opioid use disorders? As I said, these are the same kind of recommendations we make for substance use disorders more generally. But first, we think you need to know if the person you're working with has had a history of a traumatic brain injury. And it's not just any history that there can be inconsequential traumatic brain injuries. So knowing not just how to screen, but also how to interpret those results and know whether or not this is somebody who's more likely to be having these neurobehavioral problems, even if it's not in their, in any medical records they bring with them, even if it's not something they share as part of them introducing themselves to you, even if there's no visible scars, they still could be having some of these neurobehavioral problems that will need to be accommodated as part of treatment. We will think you need to then, for each individual, identify what accommodations that they might require. And that's going to require some additional skills and some resources to know what you're looking for and learn how to accommodate. But we are not talking about not using conventional treatment providers and programs. We're talking about those providers and programs adding a skill set. You're going to need to be ready to address these comorbid interactions. And again, whether mental health or more medical. And be thinking about, both in treatment and after treatment, creating those supports that will last long, if not permanently. This is kind of a throwback to what we used to do in substance use disorder treatment, where we, at discharge, really, we had an entire plan for how this person will be supported over time, particularly important for this population. And while I haven't had the chance to make the case here, we do believe that using medication-based treatments, or some use, as we used to call it, medication-assisted treatment, is even more important in this population. And it's because of the greatest susceptibility to being triggered to relapse. And so medications that would help in reducing the cue sensitivity are going to help in terms of sustaining the benefit. So finally here, what are the implications for state brain injury programs, NASHIA constituents? First, substance use disorder professionals have some training needs, some things that we need to look at how we impart, understanding just why brain injury is important, and, the connection between brain injury and executive function problems that create the underlying cognitive and behavioral control issues. They need to have the skills to screen for lifetime injury, and I would add to lifetime, they need to be able to interpret those findings and know when what amount of previous life exposure to traumatic brain injury is enough to be have your antenna up and be worrying about it. And finally, as I've already said, understanding that there are these new neurobehavioral issues, how to recognize them in treatment, as well as then how to accommodate them in your interactions with a client and or in treatment planning. There will be an ongoing need for updating this training. You might think of this as just the first bullet as kind of the core, But as new issues emerge, we need to be ready to roll out new information for our substance use disorder providers. For instance, there's new information emerging about the relationship between suicide risk and traumatic brain injury, maybe, and particularly in the presence of substance misuse and dependence. So that might be information that we would be needing to roll out as we understand it better. If it can be done, screening that is mandatory and part of just the initial assessment process is going to be more uniformly implemented than if we count on clinical staff to say, this is something I need to know. So while clinical staff skill set and awareness being raised is essential, what is even better is if screening is part of standardized admission processes so that the clinician who receives that assessment has that information to start with. And there's a flip side need that our state brain injury programs need to be thinking about, and that's that our brain injury providers, whether acute, post-acute, they also need to understand the connection between substance use disorder and brain injury and understand substance use disorder issues enough to be able to be an effective collaborative partner with individual clinicians and or treatment programs in their communities. So that's what I wanted to add about treatment, and I think Sharon's going to close it out for us here. And Sharon.
Hey, Sharon, are you there? I don't know if you're on mute or not.
Oh, I'm sorry. I said all my things on mute. I apologize.
Okay.
I
No
wanted
worries.
to say thank you for covering all of the recommendations and the overview, particular to traumatic brain injury. I'm going to cover two broad points in closing, and then we'll have some time for questions and answers. So the next slide, please. We've been doing a lot of thinking and talking about stigma, as I am pleased to say is increasingly common these days. I'm not pleased that stigma is uncommon, but that there's much more recognition about it. This graphic is to emphasize the point that each of opioid use disorders and disabilities are stigmatized, but not just those issues as a whole, but also the aspects that are related to them, such as homelessness or mental health issues that may go hand in hand with these other concerns. Further, we each have our own identities. They may also be stigmatized, and we know that there are many structural inequities in our systems that we need to pay attention to. So this graphic shows each of these Venn diagrams as separate, but really at this intersection they overlap, and we need to think about how we are engaging with people, paying attention to all of these parts that make up their whole. The multiply stigmatized concept is real, and it creates complexities that may go deeper than is acknowledged as we talk about access to care and many other issues related to opioid use disorder treatment. Next slide. I always like to end on a hopeful note. Many people recover from opioid use disorders and live successful lives as they define it. We want to encourage this process of change and ability to direct one's own life to one's own full potential. With health and well-being, safety and housing, positive relationships, and purpose and meaning. These are excellent goals for all of us and are achievable for people with both disabilities and a history of opioid misuse and other substance use disorders. Treatment engagement and recovery supports are essential aspects for many people to move those journeys forward, and that is what we are trying to help here. So in ending, I'd just like to say thank you on behalf of our team. Next slide, please. Please note that there are references and a resource page at the end of the slide deck following this slide. We're not going to go through them on the webinar here. You can reach out to those contacts and resources for more information. You can feel free to get in touch with any of us. As has been mentioned, the issue brief about TBI and opioid use disorders is available in the handouts pane for this webinar and also on our website, which is listed on this slide. We now have time for discussion, and we'll turn it back to the NASHIA folks to share any questions from the participants. Thank you for your attention.
Thank you. So I'd just like to open it up to questions. Please note that there's a question pane on your control panel. Please feel free to enter questions there. So far we've gotten a few, and I'm just gonna read them out loud, and the panelists, you guys can choose who will answer. So for the first question, it's a two-part question, and here goes. Although there is an automatic stop order for opioid dispensing, as that makes sure that the drug prescribed is 1 per day, and the prescription is for 24 hours, and the prescription is canceled after 48 hours, how does this even work? Maybe after these precaution misuse is increased. How does opioid antidote drugs have the same symptoms as that of substance abuse, that is like depression, symptom, and nervousness? And the panelists, you guys have a copy of this on your chat box if you want to take a look at it and decide who will answer.
Rachel, do you want to talk about the healthy or low risk prescribing versus higher risk?
Sure. Yeah. So, I mean, I think this question maybe is getting at some of the more recent guidelines that have come in from the CDC, and the DoD and VA have prescribing guidelines as well, which are intended to try to reduce development of opioid misuse by being more careful about the types of how many days supply are prescribed for opioids, and if it's a long-acting or short-acting formulary, and other things to consider when prescribing opioids to individuals. A lot of those guidelines have been meant for people who have chronic pain. So if someone's being treated with opioids who doesn't have chronic pain, the guidelines are not as specific for them. So I think that maybe this question is introducing the area that some of these guidelines, should in theory be reducing the likelihood to advance to opioid misuse or opioid use disorder. Certainly that's what they're intended to do. I know that go ahead. Yeah.
So I just say that, and I think our expectation would be that they would be effective, just like they're proving already to have an effect in the general population. We would think they would also have an effect for persons with traumatic brain injury. But part of what Rachel was showing is that in her data is that with any exposure, the person with traumatic brain injury may be more susceptible to moving on to misuse or addiction. So it's great we're reducing exposure, but we still may have elevated risk for persons with traumatic brain injury.
And this is Sharon. I'd also like to emphasize that we're not just talking about prescription opioid disorders, but also illicit opioid disorders. So people may be acquiring what were originally prescription opioids on the street or from friends, or they may also be using heroin or other opioids as many people do who have substance use disorders going that route. So we may still be seeing increases that are related to people who are using it beyond what's happening with the opioid prescribing guidelines.
Perfect. And that's a great segue to the next question, which is also a two-part question. Can you discuss poly-use of prescription and illicit drugs and the impact on treatment of opioid use disorders? And to add to the last question, in the context of traumatic brain injury.
Well, that is a complex question. That is more than 2 parts. It's about 10 parts. So, we know that polysubstance use is generally more difficult to treat than when somebody is, misusing a single drug. On the other hand, or maybe not on the other hand, we also know it's the most common. You deal with issues around, what we see frequently in our substance use disorder treatment for persons with brain injury is that they may be ready to change their behavior relative to one of the substances they're misusing, but not to another. And the mix of prescription and illicit opioids kind of creates that same kind of complexity. So what a question that needs a lot of attention right out of the blocks right now is that if you've had a history of opioid use disorder and you've had a period of abstinence or sobriety, but now you break a leg, what should our emergency department personnel and others, what extra precautions should be being taken to, using an opioid for that acute pain? If somebody has a prior history, we would add to that if somebody has a prior history of substance use disorder and traumatic brain injury. The guidelines, address it as a risk, but what we're not sure of yet is just how pronounced a risk it is. So polysubstance use and then adding in TBI just assures that one is working with a complex individual.
I would also add the concern about benzodiazepines in particular, because they increase the risk of overdose when you're using them with opioids. And so that's something that needs to be paid attention to in a intentional way.
Great. Next question we have here is, has the VA or other healthcare system developed a model for interprofessional care for persons with opioid use disorder and traumatic brain injury?
This is Rachel. I to my knowledge, no. The VA has great integrated care for TBI, thinking about other psychological health, which is usually mental health. And they have this polytrauma system of care that I referred to. It's quite possible in that polytrauma system of care, they are often addressing substance use disorder, which is commonly comorbid with TBI, especially in the Veterans Affairs population. But I'm not sure there's been as much specific attention to the overlap of TBI and opioid use disorder. I think to figure that out, we'd have to talk to individuals working in those settings more. Maybe some people are thinking about it, but I haven't seen an official program description. I'm not sure if anyone else knows anything.
Well, and we know there's only just a few integrated treatment programs for traumatic brain injury and any substance use disorder. So I'm really sure that for opioid use disorder, the list is even shorter.
Great. Next question, how much education is being provided to military hospital doctors to prescribe other drugs besides opioids to injured warriors?
So the military has actually been quite out in front of some of the focus on thinking about alternatives to opioids for treating pain. They came out with some reports around 2010 where they've been really trying to focus very hard on not relying too heavily on prescription opioids and thinking about other alternatives. I would say there's a good amount of education around this within the military health system. And in the military, it's very important to keep military members fit for duty and deployable. So development of a substance use disorder or an opioid use disorder is really a terrible outcome for the individual and also for the military health system. So I think that they are thinking deeply about it. The difficulty is trying to find evidence-based to date, to try to find alternatives that are helpful for people. Brandeis has been doing work in this area for over 5 years now with the Department of Defense, so we've been thinking a lot about it. I'd be happy to provide more information offline about that.
Great. And then we have one more question, so we could close out. Thank you so much for the webinar. Our state of New York has been training on brain injury for substance use treatment providers in the context of opioid overdose. It has been frustrating not to have opioid-specific info to use. The issue brief and the accommodations booklet was still very helpful. Dr. Corrigan talked a lot about screening. What are the tools to use? In the training, I present the health screening, but it's really not great for opioid overdose or anoxic injuries. Is anyone looking at screening for opioid use disorder specifically? I know that the Mount Sinai tool is proprietary. Is anyone researching medications helpful for opioid use disorder? Thank you, Margaret Singer from BIA New York.
So actually, it sounded like something got added in there at the end, but on the issue of screening, a number of states now, through their state brain injury programs, are adapting existing screening methods to make sure that they're adding anoxic and hypoxic events, both because of the prevalence in opioid use disorders and overdoses, as well as the prevalence of anoxia and hypoxia and intimate partner violence, as well as then also adding on screening for other kinds of acquired brain injuries that could be sources of the kinds of executive function problems that make response to treatment more difficult. So many states are doing it. You can contact me offline. We have been adapting versions of the OSU TBI identification method for getting at anoxia and hypoxia, as well as other acquired brain injuries.
Great, thank you. So since we're running out of time, we're going to close it here. We want to thank you all for joining us today. Please email our training and education membership coordinator at hcushion@nashia.org to join our contact list in order to receive notices for future webinar offerings and announcements, as well as to learn more about membership. To view our archived webinars and much more, please visit the NASHIA website. If you are already a member, we greatly appreciate your continued support. An evaluation of this presentation will appear soon. Please let us know how we did. We hope you have a good afternoon.